So on to my talk. Nothing to disclose, and we're going to start off with a case. So you're PGY2 in recess overnight. It's around 9 o'clock in the evening, and your fourth year comes up to you and says, hey, this is going to be a found unaltered. It's going to mean into recess 7. So this is kind of what I expect is going to be coming in. Or maybe even better, something like this. But instead it's someone who looks a lot more like this. So it's an elderly Asian gentleman. He was wearing like a jacket and a button-down shirt. So the chief complaint is found down. This is a 69-year-old guy with hypertension, and he was found down in the streets. According to family, he was just on his nightly stroll outside. During transport, he was repeatedly vomiting. So these are his initial vitals. He has a little bit of, he's a little bit tacky, but otherwise pretty normal. On primary survey, he's actively vomiting. He has equal breath sounds. He has strong pulses, and again, the vitals seen above. His GCS is a 9. His pupils are pearl, and he's moving all his extremities. When we expose him, we don't see any active bleeding and no deformities, and his EFAS is negative. So as I start doing my secondary survey, I have my third year start suctioning the airway and getting ready to intubate. On secondary survey, we see some evidence of trauma. We see some dried blood in his hair, in his nares, and also in his left ear canal. Otherwise, he has some subconjunctival hemorrhage. The rest of his exam is pretty unremarkable. And again, his GCS is a 9. So patient's intubated for airway protection at this time. And we start getting some studies back. These are his labs. He has some anemia with a hemoglobin of 9.2. Otherwise, the rest of his labs are pretty good. This is his initial EKG. These are his precordial leads. And these are his limb leads. Let me get back to the EKG. So, Eli, normal or abnormal? Abnormal. Can anyone tell me what the pattern is here? Yeah, it's a red bundle. Great. This is his CT, and we'll see if this works. And this is kind of his read. He has multiple injuries. He's got hemorrhagic contusions. He's got a posterior fossa hematoma. He has subdurals. He has subarachnoid and a little bit of shift as well. Has multiple skull fractures, including the skull base and the temporal bone.
Now that we've seen the read, can you just go back?
Sure. That's just basically just the mess of a CT scan is what it is. And so we do a pan scan on him because of unknown mechanism. We see that on his CT of his chest, he has pulmonary lacerations without any significant pneumothorax or hemothorax, and he has pulmonary contusions. The rest of his scans were normal. So in the ED, neurosurgery is consulted. They go to the bedside and place an EVD, and then they take the patient to the OR. Trauma is also consulted, and then ENT also consulted for the temporal bone fracture. And as they roll the patient away to the OR, this is kind of how I'm feeling at the time. So patient is in the OR where he needs to be getting definitive management. And so it's about 40 seconds a minute when I sit back down at my chair when I hear this. Hey, recess 7 is back. And so I walk into recess 7, and fair enough, there he is, the patient. And behind the patient is the nurse who's transporting the patient, and she looks a little out of breath. And this is what she tells me. He became braided to 30 on the way to the elevator. And to which I reply, oh no. And so I do my primary survey. Again, he's intubated, he's bagging easily. He has equal breath sounds, and he's setting 100%. But for his cardiac exam, his heart rate is 33. And his blood pressure is 68 over 53, which is badness in a setting of a head bleed. And so we place pads on him. And this is kind of how I'm feeling at that time. Anybody help me with orders? What do you guys want to order for this guy? Yeah, EKG and then some treatments as well. So here's his EKG now.
Sorry,
Yeah.
they've already placed the EVD?
They've already placed the EVD, yes. These are his limb leads. And these are his precordial leads. All right, Mark. Normal, abnormal? Abnormal. And anybody can tell me what the rhythm is here? Yeah, exactly. So this patient's in a complete heart block. So we start some orders going. We give 3% normal saline. Maybe this is increased intracranial pressure, but we start kind of treating the symptoms of bradycardia here. So we give atropine, it does absolutely nothing. We start an epidrip, brings the systolic up to about 80, but the heart rate stays at low 30s. We start transcutaneous pacing, which intermittently captures but isn't doing a great job. So we move pretty quickly onto transvenous pacing. Yeah.
Did you call neurosurgery and was the EVD?
Neurosurgery came with the patient, actually. He came back with the patient.
But the
Yeah.
EVD is draining.
Yeah. So differential diagnosis at this point. These are the ones that I came up with. Top of my differential, here's blunt cardiac injury. In the setting of a patient with pulmonary contusions, pulmonary lacerations, initially with this right bundle pattern going into a complete heart block. This is something that I had considered. Cushing's reflex, again, patient with a head bleed. But then again, you would expect to see actually hypertension rather than hypotension. And most commonly, you would see sinus bradycardia rather than a complete heart block. Again, with increased vagal tone, you would expect to see more of a sinus bradycardia. Hypothermia, unlikely given that he had a normal temperature at the beginning. Ischemia, certainly possible, but it'd be pretty bad luck to have an ischemic event on the way to the OR. Drugs, we didn't give any sort of nodal blockers, no beta blockers, calcium channel blockers, and his potassium was normal. Hypothyroidism, less likely given that he was initially a little bit tacky and his temperature was normal. So we're going to take a little sidestep here. We're going to talk a little bit about transvenous pacing, which we did in this patient. So the two sites that are advised is the left subclavian and the right IJ. At least at our institution here, cardiology likes to use the left subclavian for the permanent pacemaker, so I suggest that we use the right IJ. This is the kit that we have at our hospital, and these are stocked in the resus rooms. This is the generator. This is going to be in the resus med room. So putting in a pacemaker can be a little bit intimidating. That's a lot of steps, but I'm going to break it down into 5 key steps here. So insert the cordis, assemble the pacer wire, attach the pacer to the generator, float the pacer, and then lock and protect that pacer. So, and this is going to be, I'm going to be describing basically the crash method to do this. You can do an EKG guided way, which is going to be more accurate, but also it's going to take longer. And in this patient who's hypotensive with a head bleed, we wanted to get that in as quickly as possible. So step 1, insert the cordis. I'm not going to go over how to place a cordis. I think most of us know how to place a cordis. For the intern class, definitely something to review before you start resus shifts. This is what comes in the kit. On top of this, I usually bring a deadhead with me because there's no deadhead included in the kit. And you can either place that directly on the cordis or you can put it on the two-way stopcock that comes with the kit. Also bring some blue OR towels. They have like one drape that's like a little tiny sheet of paper in the kit. Step 2, it's going to be assembling that pacer wire. And this is what comes in the kit. So you have your cordis there pictured, and you're going to attach this kind of locking cap to the back of your cordis. Then you're going to insert the pacer wire through the sheath and through the locking cap into the cordis. On the other side of the pacer wire, this is your balloon port with the 1.5 cc syringe, and then these are the electrodes that attach to the other end of the pacer wire here. And don't throw this away. It's really easy to, but it's really important.
Rubber to rubber.
Yep. So you're going to put that at the end of the cordis. And you're going to make sure that the end is slightly loose so that you can actually thread the pacer wire through. This is your balloon syringe, and it's a 1.5 cc syringe. There's about 4 syringes in the kit, and this is the only one that has this kind of notch here. The top right shows the valve in its open position, so the valve is parallel to the syringe, and in this position you can insert the air. So once you insert 1.5 cc's, you're going to change this valve to the perpendicular position, and then the balloon will be inflated. And so this is what the assembled pacer wire looks like. You have that wire running through the sheath, and then running through into the cordis here. So step 3 is going to be attaching the pacer to the generator. So this is your generator, and we're going to be using ventricular pacing. You don't need to worry about the atrial pacing at all. So you have that gray port here, and you're going to use the gray wire. And if you're still unsure, the gray wire has that ventricle kind of sign on there. So you're going to just connect those two. This is what the part looks like at the end. And you're going to use the electrodes there, which comes in this little plastic bag. You're going to attach it to the end of that pacer. And then it goes in like that. So the positive is going to go with the positive, and the negative is going to go with the negative. So pretty simple. And then those dials at the end, which on our kit looks like it's covered in dry blood, you can turn to make sure that you tighten that and secure it. So this is the generator itself. It's really easy. You just press that on button, and then you press the emergency button. And then it's going to be in asynchronous pacing mode. It's going to be at 80 beats per minute and basically max amps current. So step 4, you're going to float the pacer. You're going to make sure that the wire is 20 centimeters past the cordis. And at this point, you know that the balloon is going to be past the length of the cordis catheter. And then you're going to start inflating your balloon. And then you're just going to advance it until you get to the right ventricle.
Sorry, can you just explain how you know it's 20? I know you
Oh yeah. So this is going to have 2 hash marks there, and that indicates that it's 20 centimeters right there. So at that position, it's going to be safe to inflate that balloon. And so you're going to keep advancing until you hit the right ventricle, and that's kind of the main gist of it. There's some tips for floating. So the wire is going to be curved, and you're going to want that curvature to be facing the left side of the patient so that it's going to be easy to, so that it's going to help you actually get into that right ventricle. The other tip that I have is to go slow, especially in these patients who are hypotensive. That's going to be very low flow going back into that right atrium and right ventricle. So if you go too fast, it's going to be really easy to just keep going and into the IVC. So go slow and use that flow to your advantage so that you get to your right ventricle. And around 35 to 40 centimeters, and that's going to be kind of somewhere between your 3rd hash mark and your 4th hash mark, give or take, you're going to start seeing pacer spikes on the monitor. Sorry, I couldn't get a picture of a monitor, but this is just imagine this is the monitor. So you're going to have your pacer spike followed by a wide QRS. And once you get that, you have capture. Now you're going to check for a pulse to make sure that you have mechanical capture and that your heart is actually beating to that pace rhythm. And once you do, you're basically there. Now, because you're at maximum current, you're going to turn that down. You're going to turn down until the capture is lost. And once that capture is lost, you're going to dial it up another notch. And then once you get capture again, that's going to be a threshold current. And then you're going to multiply that threshold current by 2.5, and that's the setting that you want it at. And this is the dial to change the current. And it says V output for your ventricular output there.
You can?
Yeah.
Does it say, I can't see it. Does it say that it's in asynchronous mode when it's in asynchronous mode somewhere?
You know, I don't think it does.
Because you have no, you turn the suppression off. So.
But you do press the emergency button, and that should be in asynchronous mode.
I'm just wondering because doing other things too, like you forgot to push the red button. How is it going to work?
Yeah, just keep pressing the red button, and
No, the default is just asynchronous, right? And that there is no suppression because it also because you don't use the atrial
So does the red button just sets the rate and the output then? Is that what this is doing?
Yeah, exactly. There's no sensing. It's just
So
going to
you
put
don't
into
really
the
have to
emergency.
do that. If you just set it
No.
at 80 and turn it all the way up.
You don't even set it at 80. You just basically just press that button and then press the emergency button, and this is what it's going to come up as.
So you just press the red button.
Yeah,
I forgot what the red button does. That's all.
emergency. Just think red button emergency. Yeah.
The only way to change out of asynchronous mode is the green arrow button, which takes you to that second screen, and that's where you'd actually toggle the different synchronous settings.
Yeah.
Sorry, the other thing is that once you get captured, take your balloon down.
Yeah, we're going to get there.
Sorry.
And so you're going to take that balloon down once you get captured. And then after that, you're going to lock and protect that wire. So you're going to use this little dial again. This is the locking cap. You're going to turn clockwise, and then you're going to make sure that that wire doesn't move anymore. And then you're going to thread that sheath over, and this rubber part is going to go over the locking cap, and then now that wire is also sterile. And it's going to look like this in the end. So again, I'm going to go over the key steps one more time. So you're going to insert the cordis, you're going to assemble the pacer wire, you're going to attach the pacer to the generator, and then you're going to float the pacer, and then you're just going to lock it. So insert the cordis, you're going to assemble the pacer wire, again, so the wire goes through the sheath, and it's going to be this. It's going to be the rubber part that's going to go on top of the cap. So it's going to be this way through the sheath, and then into the back of the cordis. You're going to attach the pacer to the generator. And again, it's going to be your on button and your emergency. And the positive goes to positive, negative goes to negative. And then once you push past 20 centimeters, which is the 2 hashes here, you're going to inflate that balloon and you're going to start advancing. Make sure to go slow. Once you get capture, make sure you get mechanical capture as well, and feel for that pulse. Adjust the current and take down the balloon. And then you're just going to lock it, and then you're just going to protect it with the sheath. So go practice. There's kits in West. I saw that there were actually 3 open kits in West, so you can practice on any of those. So let's rewind. So we had this 69-year-old guy who was found down. CT showed trauma to the chest and head. He was initially in the right bundle branch block that went into a 3rd-degree heart block. And this was the top of my differential. And this is what I'm going to be talking about today. So the objectives. So what is blunt cardiac injury? Who and how do we screen for this? And how do we treat blunt cardiac injury? Here are some of the take-home points that I'm going to be going through during this talk. Blunt cardiac injury can present in many different ways. Don't forget to screen your high-risk patients. Use standard ACLS to treat malignant arrhythmias, and then consider calling CT surgery in the right clinical context. So what is blunt cardiac injury? And it's kind of like this. So trauma surgeons can't really agree on a definition. They can't even agree on a diagnostic criteria. And some people say if you have chest trauma and you have chest pain, that is blunt cardiac injury. Some people say that you need EKG changes or you need echo findings. Either way, here are some of the injuries that are associated with blunt cardiac injury. And I'm going to go over these in a little bit of detail. So first is cardiac rupture. This is a devastating injury with extremely low survival, and people usually die on scene, especially if it's a ventricular injury. Some atrial injuries may survive to the ED and even to the OR, and you're going to be diagnosing this on a fast. Septal and valvular injuries, these often occur together. The aortic valve is the most commonly involved because you get that increase in interthoracic pressure and you get that rush of blood back into the heart. Clinical signs are kind of similar to what you would find in an acute valvular emergency. So you see widened pulse pressure, hypotension, maybe a new murmur, JVD, pulmonary edema. And you're going to be calling CT surgery for this, which at the middle of the night could kind of feel like this sometimes. Coronary artery injury presents like ACS. So you can see EKG changes, so ST elevations or even Q waves with elevated troponins. These are the types of injuries that you can see. Laceration, dissection, aneurysm with possible rupture. There's been studies done showing that even though there is local injury to the coronary artery, there's actually no thrombosis that forms, so don't use TPA. And you really should think twice or even 10 times before using TPA in a trauma patient. Otherwise, experts say that you should be calling cardiology for an angiogram once other injuries have been ruled out to shoot an angiogram to look at the injury and maybe stent versus operative repair. Here are some of the dysrhythmias that you can see. Most common is sinus tachycardia. However, please remember that the number one cause of sinus tachycardia in a trauma patient is going to be hemorrhage. So make sure you resuscitate these patients and also treat them for their pain before chalking it up to blunt cardiac injury. You can see things like PVCs, PACs, bundle branch blocks. Right bundle branch block is going to be more common, given that the right side of the heart is going to be anterior in the chest and closest to the chest wall and where it gets the most impact. You can see AFib, SVT, heart blocks, and even some ischemic changes and VTAC, VFib as well. Commotio cordis is a really interesting type of injury where you get this high velocity impact to the chest. You get this R wave on T wave phenomenon, which leads to VFib, and it's the second most common cause of sudden cardiac death in young athletes, and this is after Holcomb. Cardiac dysfunction is basically decreased contractility in the setting of cardiac trauma. It's usually temporary and resolves within 24 hours, but it can be severe enough to cause hypotension needing depressors. Cardiac contusion is a term that's kind of falling out of favor now because it's such a vague term. Classically, it's a histologic diagnosis where you would see contusion within the myocardium, but clinically and kind of realistically, people basically say if you have chest pain after chest trauma, that's probably cardiac contusion. You can also see signs like cardiac dysfunction and arrhythmias as well. So moving a little bit away from that. Epidemiology. Just kind of interesting. How many of you have seen or diagnosed blunt cardiac injury? So like four or five of you. So it's really hard to say the exact incidence of this, mainly because there's no exact definition, there's no diagnostic criteria. So a lot of people die on the scene. Some people also go undiagnosed because they just have PVCs, PACs. But estimates say about 1 million cases of blunt chest trauma, and that 20% of these are at risk of blunt cardiac injury. So maybe a little bit more than you think. So this is the EAST guidelines for screening. Not very helpful. They're basically saying anybody with significant blunt trauma to the anterior chest should be screened. And that there's no standard criteria, and that it's very clinician dependent. And I saw a little bit, but this is kind of how I imagine the boardroom of people making the EAST guidelines are like when it comes to screening. Like they don't really know. But I think it does give us a kind of a starting point. So these are some of the injuries that are markers for high-risk mechanism. So if you see somebody with a flail chest, or even chest wall ecchymosis, sternum fracture, rib fracture, pneumothorax, hemothorax, or great vessel injury, I think these are people that are worth screening for. I know it can be difficult. It's easy to forget because you have these people with pneumothorax, hemothorax, and you're excited to do that chest tube, but don't forget about blunt cardiac injury. Other signs, like signs of heart failure, like JVD, dyspnea, I think these people should be screened as well. And so the question is, do we order troponin on these patients? And the answer kind of is yes. This is from the 2012 guidelines, EAST guidelines, and they say that troponin should be measured routinely for patients suspected with a blunt cardiac injury, although it is a level 3 recommendation. They also say that patients with normal EKG and a normal troponin, you can safely rule out a blunt cardiac injury, although they kind of waffle here and say that they don't know exactly when these readings should be taken. Yeah.
I just want to mention something. So the reason why this is so difficult is that all the studies of this, including the biggest one I think that we did here on it, there's incorporation bias in all the studies, so that the thing it is that they're concerned about diagnosing in the end is the same thing they're using as the entry criteria for the study. So quite often they're measuring the troponin and saying, oh, thank God we measured that troponin, we just diagnosed myocardial infarction or myocardial infarction related to trauma. Thank God we ordered it. And the inclusion criteria for fitting into the study was a positive troponin. So it's like, well, and it doesn't change management whether the troponin is positive or not. So I'm just trying to get some context as to why this has been such a bugaboo, is that no one knows, like you said, no one knows how to define it.
Right.
And so when you have something you don't know how to define, and then you're saying you miss things, consequences if you don't diagnose it, you're going to have some trouble.
Right.
Intellectually. So they might say order troponin, but they're saying order troponin so you can find out if it's positive. Because if it's positive, you're going to say, well, they had a positive troponin. Thank God you ordered it. But it doesn't change anything. So
Right. So there's some questions, I think, about that as well. And this actually, troponin is new from the 2012 guidelines, and they didn't actually have that previously. And the reason they kind of included this is because of kind of this study, which may be the one that you mentioned, but it's done with Dr. Dimitriadis here. And this study basically showed that patients with normal EKGs within the normal troponin, 5 of these patients had a clinically significant blunt cardiac injury, which they define as
little episodes of AFib every once in a while, that's all.
Possibly. They say hypotension, they say arrhythmias, they say structural abnormalities seen on echo, decreased cardiac index that require treatment. So that's what they're saying. This is a different algorithm based off of ATLS, and here they basically say if it's a normal EKG or sinus tach and their blood pressure is normal, then forget about it. This, yeah.
Because I know that practice-wise, I've seen people also include into suspicion for blunt cardiac injury, frequent PVCs, signs of irritability, or something like that. I guess, did you see anything along those lines?
No, yeah, PVCs and PACs are definitely a type of dysrhythmia that can happen with blunt cardiac injury. And so this is the algorithm for LAC USC. The trauma surgeons here recommend an EKG and a troponin, and then if negative, a repeat at 6 to 8 hours. And so this is kind of confusing because there's so many different, algorithms here. But I think, when we look at that study that shows that positive troponin, not everybody with a positive troponin has a clinically significant blunt cardiac injury. But from that study, it looks like we do miss a couple if we don't, a couple that are clinically significant if we don't order it. And also we have to take into account, these trauma patients that get into car accidents or, whatever, we have to make sure that if we don't have a good history for why they crashed, we have to rule out, ACS or syncope or other things that may have caused the injury.
Yeah, I think that the mechanism of release of troponin is different in an acute coronary syndrome than it is in a trauma. In an acute coronary syndrome, we're talking about cells that become ischemic and then are dying, and they go through a process where they eventually release their troponin. In a blunt trauma, we're talking about smash, cells broke and troponin immediately released. And it may be, like I think it is, that the patients that had the second positive troponin in their study had a second positive troponin for other reasons, like they were shocked and they had multiple injuries. And again, a lot of the opposition to that study is the fact that they didn't, if the troponin was positive, didn't change any management. So I think it's important to monitor the patients and to see if they have PVCs, and obviously if they have PVCs, you're going to monitor them, make sure that they're safe and that it all goes away. I'm just making the point that the troponin didn't change that. I mean, you go ahead and order it, it's fine, but we don't have a study that says if the troponin is negative, that rules out badness in the future. We don't have that.
Right. Yes.
This seems very troponin-happy to me. I've never heard of this. Second troponin in a trauma patient?
Yeah.
I've never heard of that until now. So I guess now I know our protocol. But that isn't done elsewhere. Sometimes one troponin is not even done elsewhere. It's very debated, like Stuart says.
Right.
2 is, I've never heard of that.
And I think our trauma surgeons here tend to be more conservative as well. Yeah.
Well, yeah, they're conservative because the people that wrote that study work here.
Yeah.
They're attending. But, beyond that, I think you're all talking about this, but I think the other way of looking at it is if the patient has normal vital signs and they have a stomachal normal EKG, they do not have a clinically significant cardiac contusion. Even if they had a tiny release of troponin in that scenario, the chances that they are going to suddenly decompensate and get shocky or something 6 or 8 hours, it doesn't happen. So look good, normal EKG, even if they're having chest pain because they hit their chest against the seatbelt or something, it's probably musculoskeletal pain. And we don't have to worry about that. Now again, if the patient's shocky and dying, yeah, okay, whatever. Maybe that's the person that might actually have the contusion that's going to be clinically significant. They might have myocardial suppression, but that usually doesn't happen, especially acutely, without some clinical evidence of it. Right?
Yeah.
So sometimes, we're chasing our tails when we're looking at a lab test out of context. We have to put it in context of what the patient looks like.
Yeah, definitely. Yes.
We're just wondering, it's also, of the people who have significant blunt cardiac injury, some subset has required surgical intervention. Did you see any data on those patients and whether or not CT found any of those, or like, you were saying that you see cardiac thoracic should be involved, but it's where does that threshold lie? Because obviously, we want to get cardiac thoracic if we think that there's a
CT is not very sensitive for like valvular injuries, so it would be an echo that would diagnose all these. Yeah. So why do we screen? And it's it's a little difficult. So I think one thing that can help is helping diagnose injury that requires immediate intervention. So if you see ST elevations, Q waves, and elevated troponin, I think you have to kind of bring that coronary artery injury a little bit higher on that differential. Not saying that's 100% what it is, but I think you can bring that up on the differential a little bit. I think otherwise, if you have a hypotensive patient where hemorrhagic shock is ruled out and they have a troponin of, let's say, 2, then I think, again, like a septal injury or valvular injury should go up on the differential a little bit. In hemodynamically stable patients, we can rule out blunt cardiac injury to admit them to either a non-monitored setting or discharge them home. And there's studies there that show that if you have an isolated sternum fracture, that you can potentially send these patients home if you roll them out for blunt cardiac injury and they have no other injury that requires admission. And then it can also help guide the trauma surgeons once the patient is in the ICU on whether to order echoes or other testing. So we'll talk a little bit about management. So like we said, so any abnormal EKG or troponin should be monitored. And for dysrhythmias, we're just going to be doing standard management. So you're going to replete your electrolytes. It's mainly going to be your potassium, your magnesium. You're going to want to avoid hypoxia, acidosis, and then follow all other ACLS protocol. And again, if you have sinus tachycardia, make sure that you're resuscitating that patient and treating them for pain and not chalk it up to blunt cardiac injury unless you rule those things out. For clinically suspected valvular injuries, involve CT surgery. So that's going to be, again, your symptoms of acute valvular emergency. So you can have a widened pulse pressure, hypotension, you might hear a new murmur. You can also get pulmonary edema, JVD. And you're going to want to get a stat echo on these patients. It's going to be difficult sometimes, but I think if you call cardiology, who's always on call, they'll be able to come down and do one at bedside. This is a little bit tricky here. Until they go to surgery, you can consider doing some afterload reduction. This is going to be especially tough if they have other trauma, and even if they don't, they're going to be hypotensive already, and you're going to be adding that afterload reducer like a nitroprusside. So you're going to want to also be adding an inotrope like dobutamine, but again, just controlling those 2 drips is going to be really tough, and if you can get some specialists on board, like cardiology on board, I think that would be very helpful. If there's a mitral valve injury, you can consider place a consult with cardiology for an aortic balloon pump insertion for pressure support. If they have an aortic valve injury, this is highly, highly contraindicated because during diastole, that balloon is going to pump up, and then you're going to push all that blood that's already going back into the heart even more. So let's go back to the case. So we place that transvenous pacer. It captures at 80 beats per minute. His blood pressure improves to 104/69, and he's stable to go to the OR. On day 1, so this is the next morning, he's basically intermittently in sinus rhythm, intermittently in this pace rhythm. Echo was done, which was unremarkable and showed good EF. On hospital day 3, they were able to remove the pacer. He was no longer pacemaker dependent. And then hospital day 5, this doesn't actually happen. On hospital day 14, he gets extubated. And he stays in the hospital for about a month and then gets transferred to a rehab facility. And then at the time of the transfer, patient's intermittently following basic commands, and then he's also eating with the help from his wife. So, some take-home points here. Blunt cardiac injury can present in many different ways. Don't forget to screen your high-risk patients. Use standard ACLS to treat malignant arrhythmias, and then consider calling CT surgery in the right clinical context. And don't forget to practice using the transvenous pacemaker. And that's it. And some references.
reason you can't extend it right off the bat. It just keeps things a little bit cleaner, is really what it comes down to. So, and if you already attach that sheath part to the little plastic part, you can still actually tighten it with
No, I
the
certainly
rubber
can.
part. And it just removes one step at the very critical junction. So I think that it just removes a step that might dislodge things. So.
Okay, what's the best video for people to review?
There's one from, actually, Ramen sent me one from like an old USCM rounds.
Yeah, that's a good one that has all those.
Yeah.
MREF one from like.
I mean, there's an emerald.
Yeah, the Emra has like 4 videos that you can.
So,
Go
and don't
through.
feel, I mean, you're a brave soul to take on this controversial topic of cardiac contusion, because every time you'll bring up this topic, remember, you're going to get this back and forth controversy because of all these elements. And so that's one of the take-home messages. It's controversial,
Yeah.
what is it? And, you know, my contention is just like Bob's. You look at them, you treat with whatever you got. They got chest pain, treat the chest pain. They got a problem with arrhythmias, treat the arrhythmias. And that's it. Whether or not cardiac contusion exists as a diagnosis doesn't matter. I'm going to treat what I see.
job I've seen anybody do with taking this chaotic nebulous topic and putting some order into it. There's like the clinically significant ones that you know to intervene on, and then there's all the other nebulous junk out there that we don't know how to diagnose, what to do, why we're monitoring, what to do downstream, you know. But I love that you talked about at least like the septal ruptures and the things to consider. There are the intervenable types. Thank you for creating order out of this chaotic.
All right.
All right.